All right, let's talk a little bit about the mast cell. So the mast cell, in general, you can see it doesn't really have the same origin as some of these granulocytes that you see here. It's not going to come directly from the myeloblast. In fact, what's really unique, and you have to kind of juxtapose this to the basophil, is that the mast cell is actually going to mature in the tissues. So the basophil is going to come from the bone marrow, mature in the bone marrow, and then be in the bloodstream. But the mast cells, kind of like your macrophages versus your monocytes, right? The monocytes are in the blood, the macrophages are going to be in tissue specific. The mast cells are similar to that. They're going to be in the tissues. They're not necessarily observed in the blood. Okay, so that's one important distinction. Again, basophils maturing more so in the bone marrow and then coming into the blood once they're matured. Okay, mast cells maturing in the tissues. Now, in terms of the structure, mast cells, just like basophils, are going to have basophilic purple kind of staining granules. Okay, and the thing that you want to remember about mast cells, and these are really the big three here, what are in the granules? And like we said, each of these different cells that we talk about, especially when we talk about the granulocytes, like the mast cell, you have to really have some understanding of what is contained in the granules, right? You can get an image with an arrow pointing to one of these cells. You have to recognize that cell and then understand what are the really high yield things that are going to be in those granules. And in this situation, the number one thing, the highest yield thing, is going to be histamine. And a lot of the effects of histamine we discuss in the type 1 hypersensitivity video, but basically we're talking about things like vasodilation. Really high amounts of histamine can cause reactions that can cause patients to have urticarial rashes. They can have itching, right? Can even lead to wheezing and then potentially anaphylaxis or anaphylactic shock, which we'll talk about here in a minute. The other things that are released from some of these granules, heparin is a big one, and so is tryptase. Now, the reason that tryptase is probably my next favorite thing to remember in terms of these granules after histamine is because tryptase is commonly used as a marker to look for mast cell degranulation in some of these conditions that we have down here in mastocytosis, in type 1 hypersensitivity reactions where we have anaphylaxis or atopic disease. Sometimes you'll see in a board question a really high tryptase level. And so, usually in those situations, that might be your key to telling you that, hey, this patient potentially has a lot of mast cell degranulation, plus or minus basophil degranulation. But in general, tryptase is very much associated with mast cell. Now, another distinguishing factor between mast cells and basophils is the round nuclei that you're going to see in the mast cells. And sometimes you don't even see these nuclei because there's so many granules. I mean, these granules you can see here, we're looking at a couple different mast cells, and you can see these granules are very dense and they can take up a lot of space. Now, when we talk about basophils, you're usually going to be looking for more of a segmented type of nucleus. Mast cells in general will be very dark staining and sometimes difficult to see the nuclei. But if you do see them, they're going to have a more circular appearance to the nuclei. We also have these FCR epsilon 1 receptors. Now, if you watched any of the videos on, in the immunology section, when we talk about type 1 hypersensitivity, we kind of go through this whole process and, we're just going to highlight the big points here. But remember, interleukin 4 and interleukin 13, specifically interleukin 4, is going to be very much notorious for inducing proliferation of mast cells, and not just mast cells, but also the class switching to IgE antibodies. Remember, if you have exposure to some allergen, initially what will happen is you'll create an IgM response. Over time, right, you're going to have class switching occur as T cells get activated and then go on to stimulate B cells using interleukin 4 to create IgE antibodies. These IgE antibodies can then bind to the surface of mast cells, essentially sensitizing these mast cells. And again, this receptor that they're binding to is going to be this FC epsilon receptor that we're talking about here. And it's the FC portion of these IgE antibodies, right? So the IgE antibody is going to have a FC portion, it's going to have an FC portion, and it's going to have a Fab portion, right? An antibody binding portion that would essentially bind to the antigen here. And this FC portion is going to bind to the receptor like we see here, right? This is going to be the FCR epsilon 1 receptor. Okay, again, binding to the FC portion of this IgE antibody. And then after we're re-exposed to this antigen, right, some second exposure, so we're now re-exposed to this antigen, right, whatever it is, dust, pollen, whatever, binds to the Fab portion of the antibody, these antibodies will then essentially cross-link and will end up with this massive degranulation from that antigen binding. Okay, and again, we're talking about degranulation. What's degranulating? We're talking about what we just said, right? Histamine, heparin, and tryptase. Okay, and this is what's really driving that reaction you get clinically from a type 1 hypersensitivity. All right, the other thing that I want you to remember here about mast cells is that they have this c-KIT receptor. Now, of the things on this list, this is probably the least high yield, but it does come up occasionally. And the reason it does is because mutations in the c-KIT receptor can lead to mastocytosis. The mastocytosis essentially referring to a very elevated level of mast cells. And with that, you're probably going to see things like an elevated tryptase. And if you're thinking about, well, what kind of symptoms would I experience? Well, if you had mastocytosis, you'd have a lot of histamine being released. And we already kind of talked about the effects of this histamine, right? You might see things like potentially edema, right? These patients might have urticarial rashes, pruritus. They can also have diarrhea, right? And the big thing that you're really worried about is hypotension, right? Specifically, you're also worried about anaphylaxis, right? You don't want those patients to go into anaphylactic shock for massive widespread vasodilation, right? That's the thing that you're worried about. Okay, so it presents very similarly to what we talked about with type 1 hypersensitivity reactions, right? This whole process is just a type 1 hypersensitivity reaction. Now, some other situations we'll see the mast cells in that are related to the type 1 hypersensitivity reaction, right? Asthma being a classic one. We just said anaphylaxis and atopic disease in general, allergies. And then in terms of the pharmacology here, a couple of drugs to be familiar with. The first one, cromolyn sodium. What does cromolyn sodium do? Well, quite frankly, it just prevents this degranulation process. Okay, so it prevents the mast cells from degranulating. And so that's very useful in situations like atopic disease, asthma, right, where you have significant degranulation causing a lot of the symptoms. What about dupilumab, right? This is sometimes called Dupixent, is another name for this. So this is going to be an interleukin 4, interleukin 13 antagonist. So essentially, it's going to inhibit the process more upstream, up here. It's going to prevent interleukin 4 and interleukin 13, right, causing some of the class switching that we see, but also preventing the proliferation of mast cells. So again, also very classically used in atopic disease, things like atopic dermatitis. You might see this used even potentially in asthma. And then the last thing to remember, there's also certain medications that can cause non-IgE mediated histaminergic reactions. What do I mean by that? I mean that there are certain medications that can cause this degranulation step right here at the top, right? There's certain medications that can cause this without going through any of this, right? There's certain medications that will just cause mast cell degranulation. One of those, the big one, is going to be vancomycin. Okay, specifically, if you have a rapid infusion of vancomycin, it's very classic in a board question to have just widespread mast cell degranulation, not because there's IgE receptors, right? This is a non-IgE mediated histaminergic reaction. It's largely driven by the vancomycin in and of itself. Two less high yield variants here is going to be radioiodine contrast, can also do this, and then low potency opioids. These are the three, but again, the big one that I would want you to remember here is the vancomycin associated with these non-IgE mediated histaminergic reactions.